Hello everybody, today we have an interview with one of the famousest surgeon. Every time we will discuss one of the common surgical problems. Today we will discuss management of blunt abdominal trauma. Hello doctor and welcome to our studio and our YouTube channel number 1 doctor.
Hello. Thanks for you and all your channel subscribers.
A 30-year male patient sustained a road traffic accident, presented with pain abdomen in emergency department, with suspicion of abdominal injury. How will you proceed to manage this patient?
I will follow a TLS protocol of management, which includes primary survey and resuscitation, secondary survey, definitive treatment. Life-threatening injuries like tension pneumothorax and cardiac tamponade should be excluded and appropriate measures taken. When patient is stable, I will proceed with secondary survey. Secondary survey will include history, details of the nature of the injury, time of injury. In case of vehicular accident, inquire about the type of impact: frontal, lateral side swipe, rear impact or rollover. In penetrating injury, type of weapon used and the time of injury. Details about pain abdomen, site. Localized or generalized, character of pain, any shifting or radiation, aggravating or relieving factors. Any episode of vomiting and its details. Any history of hematemesis. Any swelling in the abdomen. Any history suggestive of renal injuries. Hematuria/pain or swelling in the loin. Any other injury in other parts of the body. Any history of past medical illness. Diabetes, hypertension and tuberculosis. Examination of the patient. A detailed head-to-foot examination is to be done. Examination of head, face, neck, chest and extremities. A detailed examination of abdomen. Inspection. Inspect the anterior and posterior abdominal wall and the lower chest for any external injury. Bruising or ecchymosis. Distension of abdomen. Bruise or ecchymosis around umbilicus. Flanks. Left hypochondrium. Any obvious bleeding movement of abdomen. Normal. Restricted. London sign. London sign is presence of imprint of clothing or a vehicle wheel on the abdominal wall and usually indicates a severe underlying injury. Palpation, temperature, tenderness. Suggests inflammation. Peritoneum. Hematoma or clots around liver, spleen, kidney. Tender enlargement. Percussion. Obliteration of liver dullness. Suggest perforation of hollow viscera. Hepatic. Splenic dullness. Free fluid in abdomen detected by shifting dullness. Auscultation, bowel sounds. Normal or silent. Per rectal examination, per vagina examination in female patient. Examination of pelvis and perineum. Investigations suggested. Once the patient is stable, relevant investigations should be done. Apart from baseline investigations, the specific investigations includes chest X-ray, peer view, measure, free gas under diaphragm, rib injuries, splenic injury, indicated by homogeneous opacity on left side of upper abdomen. Hematoma may compress or push fundal gas shadow. Elevation of left dome of diaphragm. Fracture ribs on left side of chest. Straight X-ray of abdomen, erect posture, measure. Ground glass appearance in peritoneum. Renal outline enlarged. In renal injuries. Perinaphric hematoma. Psoas and obliterated in peritoneum. Homogeneous opacity on right side. Liver injury. Homogeneous opacity on left side. Splenic injury. Bone injury like vertebral fracture, pelvic fracture. X-ray of pelvis. For any fracture. Forecast abdominal sonogram for trauma. FRST is a rapid ultrasonographic examination with 4 areas being scanned at the initial investigation. Scanning over the xiposternal area to exclude pericardial collection causing cardiac tamponade. Scanning over the right and left upper quadrant to exclude fluid in patelorenal pouch of Morrison and left supranex space. Scanning in the pelvis to exclude free fluid in the pelvic cavity. Diagnostic peritoneal lavage. A method for diagnosing intraperitoneal injuries by infusing a liter of normal saline into peritoneal sac and analyzing the returning fluid. Contrast-enhanced CT scan of abdomen in selected cases. Particularly solid visceral injury or retroperitoneal injury. Single-shot intravenous urography in suspected cases of renal injury. Ascending ureterography in suspected case of ureteral injury. Retrograde cystography in suspected case of bladder injury. Diagnostic laparoscopy.
What is extended fast (EFAST) examination?
It involves additional examination of pleural movement to exclude pneumothorax and assessment of pleural cavity to exclude hemothorax.
How diagnostic peritoneal lavage (DPL) is done?
Patient supine. Nasogastric tube and Foley's catheterization. Antiseptic dressing and draping of subumbilical area. Subumbilical area is infiltrated with 1% lignocaine. A 1 cm vertical skin incision is made in the subumbilical region. The incision is carried down to the linea alba and the peritoneum is incised. A 16 French rolls tube is inserted into the peritoneal cavity towards the pelvis. If more than 10 milliliters of blood is aspirated, DPL is said to be positive. If no blood is aspirated, 1 liter of normal saline is infused through the catheter into the peritoneal cavity. The patient is turned to right, left, head up and down so that the fluid is distributed throughout the whole peritoneal cavity. The saline bottle is lowered to the ground and the infused normal saline retrieved by supponage. About 75% of infused fluid should be retrieved. The fluid is examined macroscopically for presence of blood, bile or undigested food particles. Microscopically for a BC, WBC and biochemically for amylase, alkaline phosphatase.
What are the criteria to decide that DPL is positive?
Aspirate the catheter, if there is more than 10 milliliters blood or intestinal contents. DPL is positive. Lavage fluid. Criteria for a positive DPL are RPC more than 100,000 per cubic millimeters. WBC more than 10,000 per cubic millimeters. Lavage fluid amylase more than 20 international units per liter, and alkaline phosphatase more than 3 international units per liter. Lavage fluid containing bile. Lavage fluid containing undigested food particles and bacteria.
What are the limitations of DPL?
This is an invasive investigation. DPL could not identify the source of bleeding. As most solid organ injury with peritoneum is managed conservatively, so the specificity of DPL for operative intervention is low. Treatment of blunt abdominal trauma. The treatment of abdominal injury comprises resuscitation of shock. Definitive management depending on the type of injury.
When will you consider immediate laparotomy in patients with blunt abdominal trauma?
Urgent laparotomy is indicated in following situations: overt features of peritonitis or massive peritoneum. Diagnostic peritoneal lavage is positive and patient is hemodynamically unstable. Hemodynamically unstable patient with equivocal DPL. Hemodynamically unstable patient. CT scan abdomen showing major solid visceral injury. Chest X-ray showing free gas under diaphragm suggesting perforation of the hollow viscus.
Thanks, doctor.
Thanks for you and for your subscribers.
Thanks for watching. Hope to see you again in next videos. Do not forget to like and share our videos and subscribe to our YouTube channel #1 Doctor and share our videos with your friends on social media. With my best wishes.